Alrighty, next stop on our journey is looking into our emergency department data collection. And today we have Louisa Chow and Gwyneth Spicer-Wensley who manage that data collection. And similarly to the other data collections, they're going to talk a bit about what the data collection is being used for and the updates to the business rules and the data specifications and dictionary. Talk about some of the data quality issues. And there's some really, obviously ED, very interesting space, lots of new stuff coming up there. So I'll hand you over to Louisa.
Okay, thank you, Kate. Good morning, everyone, and thank you for joining our presentation. My name is Louisa Chow. I'm the Principal Data Management Officer. And on Teams, we do have Gwyneth Spicer-Wensley. She's a Data Management Officer. Both of us are working under the Emergency Department Data Collection teams. And what is the EDDC collections? Is the central data repository of WA public ED patient activity data that's sourced from the metropolitan and regional and also the contract health entities or the ED information system, which is the EDIS and WebPass ED. And our teams work with a range of the stakeholders with the Department of Health and then health support services, and also for the health service provider ED departments, and for providing the transparency of the ED patient activity across in WA. So all these data we are sharing for all the reporting, data research, and the national submissions. So how the ED data is useful? Our ED data is used in the range of the information like activity-based fundings and reportings. So we regularly submitting our data to the national labels like the Independent Hospital Pricing Authority in quarterly basis, and also for the Australian Institution of Health and Welfare, AHWA, for the annual reports, and National Health Funding Body for the biannual reports. Also, our data used quite a lot in the Mental Health Commission requests. They kindly more likely to looking at the ED for alcohol and other drugs related, and also for the sales harms related informations. Also, our data is also using our public activity and performance dashboard, like SHPR and ED overview. Those are the dashboard can access to the W Health users. And we received an ad hoc response like the parametrics questions, ministerial response, and freedom of information or media requests. So those are the areas our ED data will be using on that. And also our ED data is widely used for the research by teams in the departments and SHPs, and also for the university and other organizations. So our research project has covered a range of topics from the intersection between the primary care and emergency. Also looking at the emergency presentation as part of the whole care journey for families and cancer patients. So our research can be used in leading to the real world solutions. For example, the research on the emergency department on the triage and the primary care information like the GP urgency care champions. So those are the areas we are working on the research projects. And now I move on to the PET policy for the business updates. So I will pass on to Gwyneth to talk about that.
Good morning, everyone. Thank you for joining us today. I will be taking you through the changes to the business rules. So like many of the other teams, we got a lot of excellent feedback during the consultation process. There will be a response process managed by our fabulous policy team. So thank you to everyone who participated. Some of the feedback and ideas couldn't be implemented straight away as they require further discussion and work, but we will be looking at them. The usual kinds of changes have been made as part of the annual review cycle, updating the year, making changes where necessary to improve readability and clarity. But the biggest changes are the new sections and in the scope. The scope change is to include virtual emergency medicine, that's VEM, I'll say VEM a lot shortly, and teletriage. Previously, only physical presentations to a designated ED were included in the data collection. We've also added a section about them, and I'll go on more in a moment. We have also added a new section about COVID-19 activity. This section reflects what is already happening across the system, and we've been working with WAEDs and national bodies like IPA throughout the pandemic about how COVID-related activity should be recorded, and how we report it. We have also added a section on medical records, defining the approach and governance for ED records. This aligns with broader policies and uses across WA Health. Other big changes, we've made clearer distinctions between triage assessment and the clinical assessment and treatment provided by an ED team, just because some people were getting a bit confused. And we've also removed the references to URGs, that's the urgency related groups, because like the rest of the country, we have moved to the Australian Emergency Care Classifications, that's AECC. And so the document has been updated to reflect this. If you want to know more about the AECC, there's an excellent fact sheet on the IPA website. And we've also clarified the distinctions between did not wait and left at own risk. Okay. Now, more about virtual emergency medicine and teletriage. So VEM, mainly VEM, but also known as teletriage, is loosely defined as extending the emergency physician or doctor decision-making beyond the physical ED. It's defined as using direct video and or telephone to either link a command centre or operation centre, usually based at a HSP or a hospital, with ambulances and other settings to allow patients to be assessed and triaged before they arrive at an ED or to be diverted to another more suitable service. Another form of VEM is to provide specialist emergency medicine remotely to another hospital and care team. So VEM currently exists in WA in a couple of different ways. So WACS uses VEM for physical presentations to WACS sites, from small nursing posts to larger sites like Bunbury Hospital. And the site team can contact the Central WACS Command Centre for a range of specialist support, including specialist ED medicine consultancies. Whereas Fiona Stanley has been running a very well-regarded VEM pilot since early 2021, which connects patients, paramedics and carers and family with a SMARS command centre and virtual ED team. This team provides advice and may divert the patient to another health service, such as an urgent care clinic, or to a different ED like Rockingham instead of Fiona Stanley, or may direct to a direct admission to a ward. VEM will be expanding to pilots in North Metro and East Metro with the Minister's announcement on the 12th of May this year. This is the same announcement that included the new State Health Operations Centre, which may intersect with VEM. So as you can see, VEM is growing across WA, so these will now be in scope for ED data submissions to the collection. This is the start of a much longer journey with VEM data. The intent is for the business rules to reflect the current situation. Currently, data that can and must be stored in our EDIT systems, that's EDIS and WebPass ED, are being recorded in them and should continue to be so. But the systems aren't set up for some things, and so the teams have been recording this data that can't be stored in them in other secure systems like Web EOC. Under the changes, all WA Health System entities must provide patient-level activity recording of patients who have received VEM triage or care to the department on a quarterly basis. As VEM is an emerging data collection, information is expected to be provided on a best endeavours basis. So that's what is currently recorded now, what you've got. As I said, this is the start of a journey, and we're starting with understanding where we are and what we have. We'll be working with HSPs and data custodians and stakeholders towards incorporating VEM activity into an approved information system and into the EDDC in the future. But that's going to require a lot of collaboration between us all. If you have any questions or want to be part of the process, please contact me or Louisa, and I will now hand back to Louisa to take you through the data specifications and data dictionary changes.
Okay, thank you, Glynis. So for this year, for our data specs, we do have changes on our ED schedules, which our daily process, which we contain the past 90 days. So in the past, we have only passed update on the 28 days. Now it's 90 days. So it kind of give us more accuracy on the data quality and the reporting. And also we make changes on the optional and the mandatory to conditions. So that's kind of the data. We are kind of reducing the records in the situation where there's something to be recorded. So such as the account numbers, treating doctor type, and Senior Dr. Pai. And one of the permit value updates, which is the department status, we changed on the referral at triage to other health service. So those are the one we are, because of the Perth Children's Hospital need to have overage and underage referral cases. So that's the area we are working on. And others, after the permit value, will work with the HSS and then the data management community teams to review those retired permit values. And hopefully that will be implemented by next year's PET policies. So anything you want to be changes on the data specs, please contact us, then we will be looking on that. And moving to the data dictionary. And for our data dictionary, this year we do add on the examples around the 50 data elements. So those are the examples will give us a better scenarios how we're using the data. And we remove the rules and QA validation sections. So those rules and validation sections will be under the business rules and the data quality documents. And we kind of update on the minor changes to the permit values, data requirement, and the element names to in line with national guide and the current systems. And also thank you for other the feedbacks from the pre-consultation and consultation, and then to update those the related national definition, and then those are based on the AIHW metadata online restricted for the Meteor updates link. So now I pass back to Gwyneth to talk about the ED qualities.
So several teams are involved in maintaining and improving the EDDC data quality. Our team is currently working with ED user groups, HSPs and HSS to update the diagnosis lists for EDIS and WebPAS ED. These are pick lists used by clinical teams to record diagnoses, and we're working to make sure that the list meets the needs of all the different uses of the data across the system. So diagnoses are code and descriptor pairs in the system, and they're based on a shortlist published by IPA, which is available for download. They are used for reporting. This data is used for reporting, research, and funding, but some of the codes and descriptor pairs in EDIS and WebPAS ED are out of date. We've identified that 25 codes are used in more than 50% of the records using an out-of-date code, so addressing these is our first priority. We are working with HSS to update the EDIS list for 23 of these codes in July 2022, but this will depend on the COVID situation, of course. So we will be working with HSS. This work will continue with a review of the diagnosis list to remove all out-of-date and invalid codes, make sure that the current codes and diagnoses are up to date, and add any missing ED shortlist codes. The changes will be communicated to ED teams before they're rolled out, so don't worry. And quick reference guides and lists for the new diagnoses and removed values will be shared well before the changes are rolled out, so you'll be ready. We aim to make the changes as intuitive as possible, and the changes will be in the decision tree and searchable like normal, so it should be fairly seamless, fingers crossed. I will now hand back to Louisa.
Okay, thank you for goodness for the update on the data quality, because this year we will be still working on the primary diagnosis changes, and then what's next. So continue to do the primary diagnosis updates on the ED system and the WebPAS system. And also we will be ongoing working with the national level to make the best use of excellent works on the ED data across Australia. And we do have a preliminary discussion with the national body teams to talk about what is the VEN data and how we're going to collect those data elements and define and how we count and how we use and when we're using the data so that we can provide it to the national labels. And we know that the growth on the VENs, the virtual emergency medicine crossed to the jurisdictions in the recent years due to the pandemics. So we would like to share our VEN data within the WA and with the SHPs to have a place contribution to the national directions. And also we do have to look at the ED investigation and procedure performance in our ED. So that's currently it's not part of the national submission, but it will be in the future to be included in our submissions. So that's how we can those are preliminary data will be talk about how we count and how we use in the funding areas. And in addition to our national discussions, we also have that discussion with the contract agreement with the St. John Ambulance. So we kind of bringing the St. John's data into our department. So we do have an emergency and non-emergency plan patient transport service. So that will be under our EDDC team to share if we in the future about the St. John's data. So moving to the next, to the accessing to our EDDC master file. So we do have an EDDC master file. So any within the W Health internal users can request to accessing on the ED data, which we say is a transparency of our collections through the WA. So people requesting to the EDDC master files, we can go through, can be used as administrator in your Health SP, which is similar to the inpatient's master files. And if you do looking at your own SHP data, please contact your health information management and data teams. So that is it's a separate from our EDDC masters file. So anything related to the research or the data linkage, you can contact to the research teams or the data linkage which provided in our slides. And if you do have any questions, please send our emails to our general email data request.eddc@health.wa.gov.au for any information you request.
Thank you, Louisa. Well, gosh, there's certainly been a lot going on in the emergency department data collection, new data elements, the classifications and diagnoses lists, and the ED data business rules that are quite new. They're a year old, so they're evolving all the time, and there's certainly been a lot of work gone on this year for updating these. But again, feedback from everybody on the documents is really valuable, so that they can, I guess, mature these documents and address some of the questions that we do get from the emergency data collection. There is always going to be a lot of interest in ED data, and you only have to turn the news on, and there it is. So it is used quite extensively, and later on we'll be showing you some of the examples of how we are using the ED data. We have time for a couple of quick questions. One is, will you be looking to include private ED data into the emergency department data collection? So it is a complete picture of emergency department activity.
Thanks, Vicky. I'm Shannon Carter. I work with Louisa and a lot of the other people that you heard from today. It is a great question, and to be honest, I would love to have ED data from private facilities, because as a health system, the interaction between public and private is so close and is so aligned. At this point, we don't have any private sites that are providing us emergency department data into our emergency department data collection. We would be keen to work with private sites. So we are aware that there are some private EDs like Hollywood and St John of God. So we're very open to beginning that type of information sharing process, but we would need to sort of get that buy-in from those private sites to give us that data.
Have time for any more questions?
I think we are right on track for the next presenter.
Okay.
Thank you.
Well, thanks, Louisa. And we do have a couple of extra questions, so we will get back to those people that have submitted those.